the world, to Australia, online. Phil Stricker is, I hope, again, online.
I am.
Hi, Phil. Welcome again,
Hi.
and you will report on the fire trial. And I know it took a long time to start this trial. I know the discussions I had with Matthijs at that time in Amsterdam, but finally you succeeded, and we are looking forward to the data. Phil.
Thank you again for inviting me, and I've really enjoyed Dr. Mara's and Mark Emberton's summary and some of the key points about selection and the incredible opportunity we've got to fill a gap, which I think is a needed gap at the moment in salvage treatment. And I think one of the really important things is to learn from those papers of James Eastham and Scardino about where the cancer tends to occur in these radio-recurrent tumours, and 90% at the apex. And the other point to make is they're often paraurethral. So you have to be quite aggressive if you're in the business of trying to get a good oncological outcome. So let me share my slides. Share. Oh, hold on. That's not one. Can you see those slides? Can you see my slides?
No, not yet, Phil. You see the screen of the computer in your glasses, but not the slides on the screen here. Yes, now we see it. Yeah, okay. That's okay, Phil.
Thank you. So what I'd like to share today is a lot of work over a long period of time. And I'll not only share with you the results of the fire trial, and this is the first time we've presented it. And I have to thank Matt and Bart for double checking all the data. And I'll also give you a summary of our salvage IRE data since 2013. I have to give an apology at the beginning. Because COVID was there for the last 2 years, we had a lot of lack of compliance of the biopsy, which are only being done in the next 6 months or so. We just could not convince people in Melbourne and Tasmania, where they were having complete lockdowns, to come up to have a biopsy for research when their PSA was low. But I'll go through that. I do have a financial disclosure. I am a consultant to AngioDynamics. So the fire trial was to determine the functional and oncological outcomes of radio-recurrent prostate cancer after partial ablation. We were primarily looking at safety and quality of life, but also looking at oncological outcomes. The inclusion criteria were any Gleason score with a PSA of less than 10, limited to one side of the prostate or a single lesion, where there was good co-registration. There were certain exclusion criteria, such as a previous TURP or metastatic disease or previous focal therapy or hormone therapy. If you follow the right-hand side, you can see that after we did a very thorough evaluation of targeted and template biopsies, we then did a baseline MRI and did an EPIC questionnaire, including IPSS and IIF, did their focal treatment, and then followed them up at 3, 6, 9, and 12 months with these questionnaires. and finally did an MRI, usually at 6 months, and a biopsy at 12 months. Increasingly, PSMA fed into the study as well. We were supposed to have 40 patients. We had 39, and 37 were available for analysis. One eventually pulled out because of COVID, and one, in retrospect, had metastatic disease at baseline. So we have 37 patients, 22 had hemiablation, and 78% had quadrant ablation. If you look at the details preoperatively, one of the interesting things was the median PSA of 3.5. We were very strong believers that the lower the PSA, based on Scardino's and Eastom's paper, the greater the chance of success. So this is a highly selected series. And Gleason 7 made up about 75% of the cases. But there were 8 patients with Gleason 8 to 10. And from the two centres, my centre did 24 and Nathan Laurenchek's centre did 13. In terms of safety, we had no rectal fistulas. However, because of the aggressiveness of the approach that we treated beside the urethra, and as you saw from Mark Emberton's patient, you get a complete necrosis of this area. It's like treating a half-dead piece of tissue. 7 of these patients, or 20% thereabouts, developed a sloughing of the urethra requiring a secondary TURP, almost a cold TURP, to get rid of that dead tissue. But interestingly, none of these patients became incontinent. There were 2 patients that died during the process. Both of them were in complete biochemical remission, and both died of unrelated cancers. In terms of functional outcomes, at baseline, with an incontinence defined as greater than 1 pad, 1 patient was incontinent at baseline, and 2 out of 27 who had answered the questionnaire were incontinent after 12 months. So from this cohort, including Apex and TURs, this is a remarkably low incontinence rate. As far as erectile dysfunction goes, and that's sufficient for intercourse, obviously at baseline, the potency was only 34%, dropping to 19% at 12 months. And these are the questionnaires, and urinary symptoms and sexual function and AUA symptom score were all significantly changed from baseline. The risk factors for developing erectile dysfunction and urinary incontinence, obviously the events are too low for reliable statistical assessment, but one of the things people are particularly interested in is whether the apex is the predictor of the people who become incontinent. The ablation covered the apex in 18 of the 37 patients, or half of them. And of those, 2 patients reported incontinence at 2 months. And whilst you may speculate that the apex in those 2 patients were the cause of the incontinence, the numbers are too low. Interestingly, the 7 patients who required a secondary TURP with the sloughing of the urethra did not become incontinent. This is a busy slide, and local control at 29 months was achieved in 78 patients, which is better than most salvage series, which usually report about 50%, and probably relates more to patient selection. But you see, I've made this slide busy. One is clear of local and systemic treatment, 27 patients. One's local recurrence only, and one's systemic disease. If I concentrate on the systemic disease first, those 6 patients, 2 of them had no local recurrence. So obviously these people were just patient selection and they were destined to have metastatic disease. In the clear of local disease, I need you to see that biopsy was only present out in these 27 patients in 13. And again, the problem has been to get a biopsy in these patients when the PSA is down and the imaging is okay in the presence of lockdown in COVID. So the 8 patients with biochemical stable disease and the 8 with biochemical and clear imaging, we called clear of local and systemic disease. This should be improved before our publication with, we believe, another 8 biopsies. The risk factors to develop local or systemic disease, again, events lowish, but the only thing that predicted it, which was against what I thought the PSA would predict it, was the ISUP score at recurrence. Again, numbers are low. What we've tried to do in this slide is make a point. In the patients who had transperineal template mapping biopsies, 17 of them, 13 were clear and 14 had significant cancer. But if we did imaging on these and looked at the imaging only, 15 were clear and only 2 had recurrences, making the point that template biopsies pick up more recurrences. With PSA results, the Phoenix criteria was used as our failure in this. It was clear in 30 and biochemical recurrence based on the Phoenix definition in 7. If again you take the imaging and biopsy into consideration, only 2 of the 30 who were clear were found to be positive on biopsy or imaging. So generally, the PSA, if it's low and stable, is reasonably predictive. But if it goes up by 2 points, all of them had failed on either imaging or biopsy. This is a Kaplan-Meier curve, and it's taken out to 24 months. Because it's taken such a long time to do it, even though it was meant to be a 12-month study, this gave us the opportunity to do that. And it basically showed a progression-free survival of approximately 73% at 24 months. We found from this study that focal therapy was safe, focal IRE with reversible complications. 19% required TURP due to sloughing. 94% preserved urinary continence based on our definition. 73% required no further salvage therapy at this stage, and local control was achieved in 78% of patients. And as you know, the more likely place of recurrence is in the outfield moving forward. If I then look at our big series of all the patients who've had salvage treatment, we looked at 74 patients. We obviously took out the primary ones and the ones with short follow-up. 8 patients had a 10%, so this echoes the finding in the fire study, had the TURP, but we had 1 fistula. And this fistula was similar to what Mark Emberton showed you a second ago, that I tried to treat that seminal vesicle in a patient after a TURP with IRE, and he developed the only fistula we've had in the whole series. And he was a disaster. He had to be diverted and unfortunately is not that well. Incontinent patients in the larger series, we had no incontinence at baseline based on our definition, and 2 out of 30 or 7% based on our definition at 12 months. And erectile functioning, again, very similar, dropped by about 15% compared to baseline. Again, low potency to start with. Local control in our large series, almost exactly the same. At a median follow-up of 32 months, 77%. What's different in this group is that these people, I pressured them to have biopsies and they were my patients alone. And so this is much more based on biopsy and imaging rather than just some of them with PSA. But we allowed 5 patients to have redo IRE and included them in our success rate. So all 5 of the redos cleared their tumour. Again, the Kaplan-Meier curve comes down to around a 5-year progression-free survival of 60%, which you could argue is similar to the other presentations of cryo and HIFU and radical prostatectomy. So in conclusion, then 9% of the patients required TURP in the bigger cohorts, 93% of patients preserved continence, an additional 15% had impotence. Local control at 12 months was 91%, but that dropped down to about 80% over time, and 70% did not require any further therapy. So our conclusion from this study so far is that salvage therapy is feasible and safe and has minimal morbidity, and with at this stage, acceptable early mortality, oncological outcomes. Thank you.
Thank you, Phil. I have to congratulate you and your team to having collected these important data. And I was, as I already said, I was surprised that the toxicity in patients who had undergone a brachytherapy, a low-dose radiotherapy, didn't have more complications because that's what I expected with the initiation of this study. The other thing is, what was predictive for failure was the ISUP score. I would have predicted that it would be the time interval between initial treatment and the biochemical recurrence. Because the ISUP score is difficult to determine on patients that had radiotherapy, because the Gleason score is being validated on naive patients. And for patients that had radiation, it's more difficult to determine the exact Gleason scoring. How did you do that?
Well, if you look at that slide carefully, you'll find that the numbers of people with high-grade Gleason score were low, and our confidence limits were quite wide. So whilst it was significant, I suspect that if you are a tough statistician, and when we're going for the official publication, I think they'll reject that. I think that you're correct that we did look at the time from radiotherapy to the time of treatment, and that did not prove to be statistically significant. We also looked at the level of PSA, but because we were so careful about the level of PSA preoperatively, we didn't have many people around the PSA of 10. So we didn't really have a bad cohort like Eastham and Scardino had. So the only thing that reached statistical significance in a small number was the Gleason score. And I agree with you, of course, that the Gleason score is inaccurate, even though we have one of the top pathologists in the country, Professor Del Prado, in the post-radiotherapy setting.
Okay. Any other questions from the floor? Mark, do we have a microphone here? Yes. Mark has a question, Phil.
So Phil, again, wonderful data. So you're getting pretty close to the Scardino 50% 5-year freedom from progression, but obviously you're evaluating the patients a lot more carefully. But it's interesting that all focal salvage studies end up at the same level, but obviously differently. But that's just an observation. I just wondered your thoughts. So when I see a patient whose PSA is rising following radiotherapy, I don't know why they failed. And, did they fail because the radiation therapist missed the prostate? In other words, they were underdosed and it's residual disease. Or did they fail because the prostate cancer is truly radioresistant? So I'm asking you really whether you think there are 2 subgroups in the patients that you are treating and whether there's any difference between the 2.
I mean, clearly I'm being baited and I don't know the answer. But what was interesting was Dr. Mara's data showing that the recurrence is almost always in the same position as the primary tumour. So it's unquestionably not a field problem. It's not a new tumour. It's the tumour that either hasn't responded to the radiotherapy, or the radiotherapy was inadequate, or it simply was missed by the radiotherapy, or it's intrinsically radioresistant. Some of the geneticists and epigeneticists at the Garvan have speculation about hypoxic environment and resistant to radiotherapy. But I don't know how to measure that. Some of them will say that if you have a lot of cribriform and intraduct tumour, that's the histological sign of hypoxia. And that would mean that that should be more radioresistant. But I don't think anybody's really seriously looked at that to try and work it out. So I have to admit I don't know the answer.
Okay, once again, Phil, thank you very much, and have a nice weekend, and send my regards to Bart, and I hope we'll see him back once in the coming years in the Netherlands, because he likes it very much in Australia, and I understand, and once again, thank you very much.
Thank you for having me.
Okay, the